Today we are going to talk about the heading that is the diseases which comes under neurotic disorder. Here we are going to talk about only the headings as it will help you to organize all the diseases, and if you want to study in detail, go refer your notes. So first of all, we have the anxiety disorder. So the diseases which come inside the anxiety disorder, they are the general anxiety disorder, the panic disorder, and the phobias. See, we have talked about it Thailand in the last video, but still, GAD for 6 months, panic disorder for 1 month, and phobia for 6 months. See, the important thing which we need to remember in GAD and which is easily confusable is the level of the neurotransmitters. So, the only neurotransmitter which increases in the general anxiety disorder is the norepinephrine, while GABA and other neurotransmitters like serotonin they both fall down. In phobias, we have to remember the nomenclature of the different phobias, like what is cynophobia, what is allurophobia, and the only phobia which causes fall in the blood pressure is the phobia for blood. And I don't know what to say about this, but this is anything which causes the low in blood pressure. It's a phobia for the blood. Okay, so the second disorder which comes is under the heading of the neurotic disorder is our OCD, compulsive disorder. The important thing about the OCD is the level of damage in our CNS. At what level there is a damage? So there is a damage in cortico, striato, thalamic, cortico loop. Again, cortico, striato, thalamic, cortico loop. So cortico means here it's what structure are we specifically talking about inside the cortex? It's cingulate gyrus. Striatum means globus no, it's caudate nucleus and even putamen. Putamen is also the most common site for hypertensive bleeding, not globus pallidus, caudate and putamen. Again cortico, and then we have thalamus. Again cortico, it was the loop. Cortico striatothalamo-cortical loop. So here we have the damage in OCD. So what comes under the compulsive disorder? First we have this OCD, then we have acne expoli, trichotillomania. Here perifollicular hemorrhage, non-scarring alopecia, all these MCQs come. Then we have this hoarding disorder. The important thing about a hoarding disorder is CBT is more useful than EPR. Oh, no, sorry, electric response prevention. Then we have fifth disease, which is BDD, body dysmorphic disorder. So, OCD, we have OCD, acne coli, trichotillomania, body disorder, and body dysmorphic disorder. The third group of disorder which comes under neurosis is the disruptive impulse and conduct disorder. Very important, conduct disorder and ODD. Then we have kleptomania, pyromania, and intermittent explosion. Okay, see, there is an MCQ approach for approaching specifically this disorder. If in the clinical vignette you have an angry patient, so there are several differential diagnoses which you need to be thorough of. First of all, you have the conduct disorder and ODD, open hand deficient disorder. See, in the conduct disorder, the level of crime will be more serious. The patient will get physical with the other one. While in the ODD, it's not that serious. Here, it's a level of aggression which is shown verbally, okay, against the person who is in authority. While here, they will get physical, fire, all these kind of offenses which are more severe comes under CD, while the offenses which are more on lighter side, they come under ODD. And another childhood disorder is, I would say, disruptive mood dysregulation. Here, a child should be less than 10 years old. This should be present for more than 1 year. And here, the typical scenario that the examiner will give you is the angry child whose anger is out of proportion. Out of proportion. A child should not get angry below above this level, but here his anger is out of the proportion to for a 10-year-old child, less than 10-year-old child. Okay, and then so these are the children disorders, while the adult disorder. Here we have the typical scenario that will give you, that they will give you is you have an angry adult who gets angry easily and then he gets relieved by the anger. Person feels relieved. So here it is intermittent explosive disorder. Intermittent explosive disorder. Okay. So here we have talked about that third disorder, which is the impulse conduct disruptive. The fourth and fifth, they are, the fourth one is very important, trauma and stress. We have talked about them in our last video. It is acute stress disorder, PTSD, and adjustment disorder. But one of the disorder which I want to talk to you about is DABDA. That is, so whenever you deliver a news which is not in accordance with the patient or anyone, he or she goes through these phases: denial, anger, bargaining, depression, acceptance. Again, denial, anger, bargaining, depression, and acceptance. So the important here is depression. If the patient is depressed or sad for like 0 to 6 months, then it's normal. If the patient is depressed for more than 6 months, then it becomes the pathological grief. Well, here this is the normal grief. Inside this normal grief, if the patient starts seeing that person, for example, you have bombarded the news of death of a loved one to a person, and within 0 to 6 months only, that person starts seeing the person who is dead. That it's not hallucination. It's only a basement reaction. It's normal. Okay, it's not an hallucination. And why we see in the last video we have talked about that depression should be more than 2 weeks, but here it's of 6 months. Then why do we call it depression? See, for calling a depression, there should be no any objectiveness. Here we have a objectiveness. A loved one is dead. That's why we are calling it a normal grief. And if it's more than 6 months, then it becomes a pathological grief. It's simple. And they are very important and they easily confusable disorders and the somatiform disorder. And what do we have in somatiform disorder? You have to divide it. Unconscious, conscious. Here the patient is unconscious of what he or she is doing, and here he or she is conscious that he or she knows that what he or she is doing. Here the patient doesn't know. Here he or she knows. So here we have mainly three disorders. One, two, and three. So starting off with the easiest one. If the unconsciously, patient unconsciously creating or producing CNS, that is neurological symptoms. Specific, be specific to the word CNS. So here we call this disorder as hysteria or conversion disorder. Okay, hysteria or the conversion disorder. Now, here patient asks for confirmation. Example: MRI for brain tumor, HRCT for lung cancer. So, oh, here it is illness anxiety disorder, also known as hypochondriacs. Then here patient asks for pain relief. Then somatic disorder. Okay. So these three disorders are very important. Here the patient produces specifically CNS symptoms. Here the patient asks for the confirmation. Then it's illness anxiety disorder, also known as hypochondriasis. Please do not get confused between hysteriasis and hypochondriasis. And the patient asks for the pain relief. Then it is somatic disorder, somatic body disorder, or the pain disorder. Okay. Now, in all these conditions, the patient is unconscious. That is the patient doesn't know that he or she himself or herself is producing the symptoms. While uh, the patient, when he or she is conscious, that yes, I know I am producing these symptoms knowingly or unknowingly. So here you have to see for the secondary gain. It is what is the person's motive. What is this person's motive for producing this kind of symptoms? If it is if the secondary gains are positive, well, if they are present and present in a sense that that person is using this for getting a leave from the office or law to get rescued from the law, then it is malingering. Call the police. And here, if the secondary gains are absent, that is, person likes to assume a sick role. Person likes to be in the hospital for no obvious reason. Then this is factitious disorder, Munchausen syndrome. Okay, so these two are very different. Secondary gain present and absent. So these are the somatiform disorders. And thirdly, and the sixth, we have the dissociative disorder. Anyone it is Pila, huge, huge disorder, identity disorder. Then we have the depersonalization disorder and amnesia. See, in the fuse, the person takes a new identity. In the identity disorder, this is the typical opposite multiple personality disorder. In the depersonalization, you have the acid phenomena, and the amnesia. It is a retrograde amnesia more than anterograde amnesia. Okay, and इसका DD has pseudo amnesia, where it is also known as gangster syndrome. The patient will give approximate answers, like the graph is orange. Okay. So these are the important neurotic disorder. Again, I just told you the headings, which will help you in the categorization of this disorder. Thank you.